Hello, anatomy colleagues. This is Dr. Alsop. In this last video for session 2, we are going to focus on the anterolateral thoracic muscles. And this is a fairly long learning objective. We're going to talk through some of the attachments, but not all, of these muscles, as well as actions and innervation. And the three muscles we are focusing on are pectoralis major, pectoralis minor, and serratus anterior. And we'll talk through a little bit of the clinical significance of these muscles based on our understanding of those attachments, actions, and innervation. So let's start with the biggest one and the most superficial, and that's going to be the pectoralis major. This is the largest. It's the most obvious muscle of the anterior thorax. It is going to have various attachments on the sternum and the clavicle, and it will have its distal attachment on the humerus. And the fact that that's where the distal attachment is means that it crosses the shoulder joint and can affect action there. And this muscle actually has a dual innervation. It's going to be innervated by two different nerves. Both have a pectoral in the name. It will be the lateral and the medial pectoral nerves. Now, the pectoralis major is going to play a role in most actions at the shoulder joint, except for abduction or moving the upper limb in that coronal plane, as well as it doesn't play a role in terms of lateral or internal rotation. And really, its most powerful actions will really be in adduction or adding the upper limb back towards the midline region, as well as medial and internal rotation. But again, it can play a role in some of the other actions as well. And if you would like, there are videos that are embedded within this PowerPoint that show you what these different actions are. So it will show you what arm abduction is, even though that's not one of the major actions, but it will show adduction, as well as medial and lateral rotation and flexion and extension. So go ahead if you would like to do those on your own time to get a better understanding of what these actions actually look like. Now, clinically, this muscle is going to play an important role because of its proximity to breast tissue. So the actual muscle, as well as importantly, the fascia that surrounds it, they're frequently encountered or even resected during any type of surgery associated with breast tissue. So that's a really close relationship here. If you're looking, there's the breast tissue, and then just deep to it will be the pectoralis major. Now, the smaller partner of the pectoralis major is, as its name would suggest, minor, so that pectoralis minor is going to be located just deep to the pectoralis major. So if we're looking and thinking through this particular illustration here, the pectoralis major has been completely removed in order for us to see the entirety of pectoralis minor. Now, this muscle is going to be an important surgical landmark, particularly in surgeries associated with the axilla. It has a very close relationship to the axillary artery, which supplies blood to the structures in the shoulder axillary region. Now, this muscle is going to be innervated by only the medial pectoral nerve. So remember, the pectoralis major was the medial and lateral pectoral nerves. Pectoralis minor is only innervated by the medial pectoral nerve. And what's unique about this nerve is that it actually pierces through the muscle. So if you see a nerve that looks like it's just kind of bursting out through between the fibers of the pectoralis minor, that's going to be the medial pectoral nerve. Now, this muscle is going to have its proximal attachment on ribs 3 through 5, and its distal attachment is going to be on the small process on the scapula called the coracoid process. So this muscle does not cross the shoulder joint. It does not attach on the humerus. So it's really only going to play a role in terms of moving the scapula. And really, its major action, or its major function, is to stabilize the scapula in other types of movements, particularly movements with that full range of motion that happens with the shoulder joint. But forceful contraction of the pectoralis minor can play a role in terms of an action called protraction of the scapula, where you can kind of see the scapula is moving laterally. The last muscle we're going to discuss is the serratus anterior, and it's named because it has this serrated appearance. It looks kind of like a serrated knife. It has these individual attachments on these different ribs, ribs 1 through 8, and then it will go and attach onto the scapula. So again, this is another example of a muscle that does not cross the shoulder joint, so it will only affect the actions of the scapula. And specifically, this muscle will also play a role in terms of protraction of the scapula or moving it more laterally. And it will also play a role in terms of the upward rotation of the scapula, particularly the glenoid fossa part, which is the portion of the scapula that actually articulates with the humerus. So allowing for the scapula to be rotated upwards will allow for that full range of motion that actually comes at the shoulder joint. So in order to get full flexion or full abduction of the shoulder joint, you're going to need to move that scapula as well. And so the serratus anterior muscle, as well as the pectoralis minor, will play a role in that. Now, this muscle is going to be innervated by a nerve called the long thoracic nerve. And it is unique in the fact that this nerve will literally travel along the superficial portion of the muscle. Most nerves that innervate a muscle will travel deep to the muscle belly. That is not the case for the long thoracic of the serratus anterior. It's going to be running superficially. And you can think about how that actually, that functionally, that could be an issue. Say you had some form of a lesion or a wound that's happening to the lateral side of your thorax. It's going to be more likely for the long thoracic to be injured because it's running superficial or in comparison to if it had run deep. And the long thoracic nerve is going to be a nerve of the plexus, of a plexus. And so it's going to be derived from axons from 3 different spinal cord segments. So C5, C6, and C7, they're all going to send certain fibers to form the long thoracic nerve. And so you may hear this mnemonic C5, C6, C7, keep the wings from heaven. And what that means is that if you have injury to the long thoracic nerve, it will cause what is often referred to as winging of the scapula. So it will cause that back portion or that portion of the scapula to look like kind of wings. And specifically, the type of winging that lesions of the long thoracic nerve will cause is medial winging. So that scapula will rest more medial than typical because the serratus anterior isn't capable of producing that effective protraction. So remember we said protraction is moving that scapula lateral. Well, if it can't do that, then that can cause weakness and it can cause for the scapula to just sit more medial than it should or than typical. All right, excellent. So these are just a few of the thoracic muscles. These are 3 of the bigger ones. Here is a summary slide for you. You'll see some of the bigger picture things that we want you to focus on. If you have any questions regarding any of these concepts, as always, please feel free to reach out to us. Have a great rest of your day.